Good afternoon again. We're going to have another interesting and very common problem, topic on the interesting and very important problem of obesity. And we are honored to have eminent speakers from India, who is no other than Professor Nitin Kapoor, who has who holds the position of Professor Head of the Department of Endocrinology, Diabetes and Metabolism, Christian Medical College of Vellore, India. And I have a privilege to introduce you briefly about his curriculum vitae, because we all treat it will take times. Actually, he has more than 350 PubMed index peer-reviewed publications in national and international journals. He's also one of the prolific, most prolific authors in from India, like Sanjay Kalra. Is one of his friends, you know. Yes. Almost every second they are publishing papers. Now, how come you can do that, right? Anyway, we are very much envy you for your effort and capability. Dr. Professor Nitin Kapoor, actually he has completed his diabetes and postdoctoral fellowship endocrinology in CMC Vellore, and he then completed his PhD research on clinical and genetic indicators of obesity from the University of Melbourne, Australia. So in other words, he trained endocrinology in both India and Australia. He's being cited as among the top 2% of the most influential researchers across the world by Stanford University, USA, in October 2023 and September 2024. So it's, we are very privileged and we are very honored to have a very eminent speakers and writers, authors for the obesity and diabetes here. And recently, he was also awarded the President's Awards of Appreciation by the Endocrine Society of India in December 2022, and the Best Mentor Award of the year 2023-2024 by the Director of the Christian Medical College Vellore. He's a good teacher, no doubt, because although some of you might not know him, most of the endocrinologists, we are very familiar with him because he has conducted at least 4 online endocrine quicks. I think 4 times, no? Nitin?
Yes, sir.
Yeah, so he's been with us for the last couple of years already. So it is my pleasure to introduce Professor Nitin Kapoor for the lectures, New Frontiers in Obesity Management. Both the chairperson and both the speakers for this section, although we are not small persons, we are going to talk about the obesity. It is mainly for the public, not for the doctors. Okay, just for a joke. The floor is now yours, Nitin. Please go ahead.
Thank you so much, Professor Latt, for that very, very kind introduction. It's indeed an honor and privilege to be back here in Myanmar and talking on obesity. Really appreciate the invitation, Professor Koko as well, Professor Tint and I. And I would say that it's not only a great conference, but really well attended, really high in academics. So big congratulations to all the senior organizers of this particular meeting for organizing such a brilliant conference. In the next couple of minutes, I shall take you through this topic of new frontiers in obesity management. And I thought to make it simple, I will try and answer just 4 simple questions. I will answer 4 questions, that is the how, why, what, and where. We'll see how the obesity landscape is changing across the world, but in South Asia, and especially looking at some data from Myanmar as well. We look at why is it important for us to change our obesity assessment strategies. How the global, literature is now moving away from just using the conventional BMI, but using more other important clinical parameters for assessing obesity. Talking about new frontiers, I'll also talk about what are the emerging complications. I'm sure all of us as clinicians, physicians in this room are used to assessing the metabolic issues associated with obesity, but what are the other emerging complications that we often don't do in clinical practice but are really important? And last but not the least, the field which is just booming in the last 5 years, where the newer management strategies for obesity management are really taking us forward. And that would be the outline of my talk. So let's get started with the first aspect, how the obesity landscape is changing. Now, all of us who are clinicians, and when we have a patient that walks into our clinic, maybe for diabetes management, maybe for hypertension, cholesterol, or whatever reason, and sometimes even for obesity management, when we look at this patient from an obesity lens, we would classify that patient to have either normal weight, or we would say this patient has obesity or is overweight. And sometimes in clinical practice, we will also see some patients who have morbid obesity or very severe obesity. But how do we do this classification? How do we classify in our clinic somebody who's normal weight, overweight, obese, or severely obese? And we do that with the help of two things. We look at one obesity indicator. We choose an obesity indicator in clinical practice, and we choose a cutoff for that indicator. And worldwide, the most common obesity indicator that has been used globally, I'm sure here as well, is body mass index. Body mass index is not something new. This was described 200 years ago by a Belgian mathematician. Simple formula, weight in kilograms divided by height in meters square. But over the years, literature has told us that when we talk of the Asian population, be it South Asia or Southeast Asia, we've realized that BMI is not one of our best indicators for obesity for our population. And therefore, when we plot complications like diabetes against obesity for different countries, we see that our South Asian countries are one of the highest in terms of the prevalence of diabetes, but not really so high in terms of prevalence of obesity. And there seems to be a paradox here. We have a huge problem of diabetes. We have many patients who walk into our clinic, may not look very obese, but they may still have diabetes, hypertension, cholesterol, but they do not look very obese. This was looked at by a study that we did in the community a couple of years ago, looking at 5,000 people. What we were looking at new onset diabetes in people who have a BMI of less than 18.5. And we were surprised that 1 out of 20 people in this particular study had new onset diabetes with just a BMI of 18.5. So yes, so we talk about obesity classification, but when we are talking of obesity in the Asian context, we have this other phenotype that we also need to know about, which is normal weight obesity. This is not something very new. This was a term which was coined by Lorenzo way back in 2006. But more recent literature talking about normal weight obesity in the South Asian population has emerged, wherein people would have a BMI in the non-obese range, a BMI of less than 25 kilograms per meter square, but will have high body fat percentage. And again, different cutoffs for high body fat percentage are used. What is used or proposed by the Indian Endocrine Society is something more than 25% in men and something more than 30% in women. So how common is this phenotype? We looked at that particular aspect from a study that we did in India a couple of years ago. We found that 1/3 of this community-based study population had high body fat with less BMI, or BMI which was non-obese, less than 25. When we looked at the prevalence of diabetes, hypertension, and dyslipidemia in this population, it was very high as compared to people who had significant obesity. And when we look at global literature, we find this particular phenotype is very common in the Asian population. So when you're talking of new frontiers of obesity, we know the obesity problem is increasing, but when we're talking of the South Asian region and the Southeast Asian region, we find that countries like India, China, even probably Myanmar, we have people who may look normal weight but may have high body fat. And therefore, the metabolic problems of obesity are more common. So this was showing that the prevalence of this particular entity in our population in India is about 30%, but we looked at what happens to them when we follow them up over a 2-year follow-up period with lifestyle intervention. And we found that these patients with normal weight obesity don't do very well. Very minimal improvement in blood pressure and cholesterol is what we found, but by and large, these patients were very resistant to change with a 2-year lifestyle intervention, even though other parameters like diabetes, hypertension, in other population who were obese improved, but normal weight obesity phenotype was resistant to change. And though this study answered some questions, it raised more questions, and we thought whether our type of obesity requires a more strenuous but more long-term intervention. And then we got funding for the same cohort. We followed up for a period of 9 years, and we just got the data out. This was published and presented at the IDF meeting in Bangkok earlier this year. And if in one line I have to summarize what happens to people with normal weight obesity 9 years down the line, I would say they have higher cardiovascular events than people who are having normal fat. They have higher mortality, higher admissions, higher vascular events. So in cutting a long story short, our phenotype of obesity is just not BMI based. We have this phenotype of normal weight obesity, which is common, which is more resistant to change, and is associated with significant comorbidities when we follow up these patients for a decade or so. And this is endorsed by the national guidelines in India, both by the Endocrine Society and our Diabetes Society. So that's the first point I wanted to say in epidemiology, that what are the new frontiers? The first is that we have this phenotype of normal weight obesity. But what about obesity? What about overweight and obesity? How is that data changing in the South Asian region? This was a publication we wrote a couple of 2 years ago, where we talked about national obesity risk. The World Obesity Federation now gives each country a score, a national risk score for obesity, and also a risk score for childhood obesity. And when we compare India and Myanmar, our risk scores are exactly the same. We don't score very well. Our countries are showing that the obesity rate, the obesity prevalence, and our readiness for managing obesity is not that great. Our countries have a national obesity risk of 7 on 10. When we look at hardcore data, again, this is provided by the World Obesity Federation. This is data from Myanmar. What we find, and this was mentioned yesterday in the opening remarks, also by the health minister, and we look at the prevalence of obesity in Myanmar, especially in women, is as high as 30% together, overweight and obesity, which is huge, 1 in 3. Not only this, even children between the age of 13 to 17 years have a huge prevalence, about 8 to 10%. 1 in 10 children here would have obesity in a very similar state, even in India. So cutting a long story short, talking about the first aspect of how the obesity landscape is changing, our prevalence of overweight and obesity is increasing. We are also increasingly recognizing the unique phenotype of the South Asian region, which is associated with normal weight obesity. So with this, I move on to the second question that I want to address, and why do we need to change the assessment strategies for obesity? As I mentioned, one of the most common ways of assessment of obesity is BMI, but there are several other ways as well. We can look at waist circumference, waist hip ratio, waist height ratio, more recent literature on wrist circumference, neck circumference. We also have body fat percentage, visceral adipose tissue assessment. So there's so many ways in which we can assess obesity. And over the years, we've looked at waist circumference being an important parameter when we talk of obesity risk assessment for the Asian region. More recently, body composition analysis, body fat estimation has become a big fad. But again, in our countries, we do not have access to DEXA and body fat machines very easily. So there are clinical ways in which we can assess body fat. Very similar in patients with chronic kidney disease. You find out GFR, you just estimate GFR. Nobody measures GFR. We just plug it into a formula, look serum creatinine, body weight, age, and we use that formula to estimate GFR. And very similar for visceral adipose tissue as well. We can use very simple parameters like weight, triglyceride, fasting glucose, and all these parameters, when we put up, we are able to estimate body fat. But the point that I really want to drive in terms of assessment of obesity is the global literature is now moving away from just looking at obesity in terms of numbers. They are saying it's okay if you want to look at BMI, waist circumference, waist hip ratio, but then there is more to that. than just looking at numbers. And most international guidelines today endorse what we call as the Edmonton obesity staging system. Like for patients with cancer, we stage cancer. Similarly, for obesity, if there is a new frontier in assessment, I would say it is a staging system for obesity. Now, what is the staging system for obesity? This is the Edmonton Obesity Staging System, which looks at not only the medical problems, but also the psychological and the functional problems. And I'll be able to stage a patient with obesity based on this and not based on numbers alone. I'll give you an example. I may have a patient who's coming to my OPD for obesity management, has a BMI of 34 kilograms per meter square. With that BMI, I do the metabolic workup, and I find that patient has pre-diabetes. So that patient, I would put it as stage 1. That's the place where I would say this patient belongs because there are preclinical medical risk factors. I may have another patient who walks into the OPD on the same day, but that patient may have a BMI of 29, which is much less than my previous patient. But that patient comes to me on a wheelchair because she's got severe osteoarthritis of the knee. And therefore, that patient would directly jump to stage 3, right? So this is helping us to look at the patient based on their comorbidities, not based on BMI. Now, why is this system better than BMI? When we look at this study, which is follow-up of over 15 years, using the NAINS database, we find that these patients, if I use the EOS staging system, I'm able to predict mortality much better in them than when I use BMI. When you're talking of new frontiers of assessment, I would say staging systems for obesity are something that are coming more and more in vogue than talking about just assessment using anthropometric indicators. These are very simple clinical systems endorsed by the Indian societies as well. When we looked at our own data at 𝗬𝗏, we run a multidisciplinary obesity clinic over there where we have the endocrinologist, the dietitian, the physiotherapist, the psychiatrist. We found that about 2/3 of our clinic population have obesity staging between EOS stage 2 and 3. And that tells us that they are really having significant amount of obesity-related complications. The Endocrine Society of India also gives an algorithm how to manage these patients with the help of this staging system. So you might recommend medications for obesity, which I'm sure are about to reach Myanmar very soon, but you may decide that not based on BMI. You may have a patient who's got severe complications of obesity at a lower BMI and may still deserve to get those medicines, whereas somebody who's got a higher BMI may still not require them. So that was the second point I wanted to share. Why do we need to change our assessment strategies? And I move on to the third aspect about what are the emerging complications of obesity in terms of the new frontiers. So if we were to count all the metabolic and all the complications of obesity, I could list about 250 comorbidities associated with obesity. And the point is not to say that obesity is associated with it. The point is to mention that for all of us as physicians, as specialists, maybe orthopedician, I will see obesity as osteoarthritis. As a lung specialist, I would see it as sleep apnea. As a liver specialist, I would see it as fatty liver. The point is, no matter what discipline we practice, we will see patients with obesity in that decision. And all of us have to be abreast with the latest in the field because all of us will see patients with that particular comorbidity which is pertaining to our specialty. Most of us as physicians in this room would do a very good job in assessing the metabolic aspects of obesity. But we often would not look at the mechanical and the mental complications, the psychological aspect. And even if we do look at mechanical, I think the psychological aspect of obesity is something that we often would miss and is something very, very important. When we looked at our own data from 𝗬𝗏, in our obesity clinic, we found that about 30% of people who walk in to our obesity clinic have an underlying psychological issue that needs to be addressed, and depression being most common. Not only in terms of comorbidities, but the psychiatric aspect also talks in terms of stigma. And this is another study that we did where we found that patients with obesity, we all know that they're often stigmatized in the society, but in the study we showed that it's a vicious cycle. Patients who are stigmatized for obesity tend to develop further on habits that promote obesity, and that leads on to a vicious cycle. This is another important aspect that we have to deal with, and definitely having a psychological assessment and a psychiatrist on board while managing obesity is something which is really, really important. Not only for diagnosis, not only for comorbidities, but even for treatment as well. Using intensive behavioral therapy is one of the most effective, but I would say underutilized way of managing obesity. So that was the third aspect that I wanted to cover in terms of what are the emerging complications associated with obesity. And with this, I move on to the last but the most important aspect, where the newer obesity management strategies are taking us. Let's start with the first step in obesity management, which is lifestyle change, both diet and exercise. So we are sure that we've all heard of so many types of diets that are available for obesity. Many times patients would come and tell us, Doctor, so-and-so has lost so much weight with intermittent fasting, so much weight has been lost by keto diet, which diet is the best diet? Well, if you look at all the diets for obesity that are available, I would be able to classify these diets into two aspects. One would be a diet that would restrict calorie intake, whereas the other type of diet would be a diet that would change macronutrient composition. So in a keto diet, I'd like to give more fat. In another type of diet, I'd like to give more protein or lower carbohydrates. But by and large, which diet is the best? Now, there are several meta-analyses which have looked at head-to-head comparisons of these diets, and believe me, the single-line answer is no diet is the best. All these diets can produce similar amount of weight loss, but only and only if my patient is able to sustain the diet for a long time. Many of us would be able to do intermittent fasting, but if we do it for 6 months, we lose weight. The moment we stop, we gain, and we often gain more than where we even started with. So what is the secret for a long-term sustenance diet? Is a patient-centered dietary approach. Gone are the days where in practice we would just give a pamphlet to a patient with do's and don'ts for diet to lose weight and expect that patient to lose 5 kgs of weight and come back. That's not going to happen. It's important to understand what is the cultural background of my patient, what is the kind of diet that they consume. And maybe as a first step, it's just good to change the proportions of the same diet that they consume. Maybe increase the amount of protein that they have, reduce the amount of carbohydrates that they have, be it rice, be it noodles, be it pasta or whatever. But changing the proportions of the diet which are commonly made by that patient's house already, and maybe changing that itself would be the first step. So addressing the diet of the patient, it's not important what diet to prescribe. You ask the patient which diet can they follow long term. And that is what I would say is a newer frontier in management of diet. And this has been proven in several studies. These are 2 studies that we've been involved with. We published the pilot study, and now we're doing a big multicentric study looking at individualized diet in women with PCOS. And even though this is a 5-year study, last week we had the interim results. And again, I can share with you unofficially that the people who've got this person-centered diet have a much higher carry-home baby rate as compared to people who have not got the person-centered diet. So yes, person-centered care is something important. A few other points in diet is obviously in the Asian context, again, to improve the protein intake in the diet. Again, this is data from our own center where we looked at patients who are coming and consuming even 200 times the amount of calories that they have to, but they still do not eat the amount of protein that they have. Talking about high fiber, which is also something very important that we have to encourage our patients. Another newer frontier, and we've been talking about obesity in a big way in terms of macronutrients, but more recent literature is also talking about the role of micronutrients for obesity management, talking about importance of iron, importance of zinc, importance of B12 also in obesity management. The next step is medications, and as I'm told, you're going to have newer anti-obesity medications very shortly in Myanmar, so you'll be using them. Already some people are using, but you'll have it in the market to prescribe to your patients very soon. I think the 2 drugs that are likely to come, 𝗙𝗵𝗔𝗏 very soon and also semaglutide, we'll focus on these 2. These were the drugs that are approved by US FDA for many years, but not really very effective for treatment. But after the advent of GLP-1 RAs, we have very, very effective therapies for obesity. At this point, if you look at the current treatment strategies for obesity, they're basically targeting 4 receptors, that is GLP-1, GIP, amylin, and glucagon. The first drug that came in was semaglutide. This was a landmark paper published in NEJM in 2021. First time an anti-obesity drug like injectable semaglutide caused 15% weight loss. This was a step 1 trial. There have been several step trials after that. Step 11 was published recently, and that's using semaglutide in Thailand, in the Southeast Asian population, again shown to be very effective. We also now have data for how these drugs are not only effective for weight management, but also for obesity management as well. Apart from semaglutide, the other drug that is likely to enter the Myanmar market is 𝗙𝗵𝗔𝗫𝗍, which is a dual agonist of GLP and GIP. The quantum of weight loss this drug can cause is about 21%. This is the first time that we've had a drug that nearly reaches what a bariatric surgery can achieve. And to summarize all the newer drugs that are either available or likely to come in the market very soon, I would say this is a slide in this paper. You see the most effective drug that is likely to come here is retatrutide, that is 25% weight loss, but definitely both injectable semaglutide and injectable 𝗙𝗵𝗔𝗫𝗍 is going to come here very soon. Do these drugs have side effects? Yes, they do have. They have a lot of nausea, vomiting. You should not use these drugs in patients who have past history of pancreatitis, of hereditary thyroid cancer, but that's rare. Again, if you start these drugs at a lower dose, build up gradually, patients do tolerate it much better. This is a meta-analysis we looked at, looking at how the side effects of these drugs can be not very different as compared to the placebo. And in the last minute that I have, talking about intragastric balloon, intragastric devices is also something that we've been using in Vellore for obesity management, causes about 15 kilograms of weight loss, has some specific indications, and bariatric surgery still remains the king of obesity management till we have these drugs which are much affordable for our vast population. So friends, with this I conclude the 4 aspects that are really covered in this talk in terms of newer frontiers of obesity management. We looked at the obesity epidemiology. We looked at the new phenotype of obesity in terms of normal weight obesity, looking at follow-up not only at 2 years, but even 10 years. But we also looked at the prevalence of obesity in South Asian countries like Myanmar and how we all are in the same boat in terms of the same national obesity risk score, which is provided by the World Obesity Federation. Why we need to change assessment strategies. We looked at different obesity indicators, but we saw how the global literature is now moving towards staging systems of obesity. Emerging complications, we do a very good job with medical problems. Do not ignore the psychological aspects, which is also a very big component, not only of obesity comorbidities, but even therapy as well. And last but not the least, treatment strategies. I think all of us need to be abreast with the latest, because we all would see patients with obesity, no matter what specialty we practice. We have to know about these newer anti-obesity medications, which are highly effective, how we need to prescribe, which ones are going to be available. I think we all need to be aware. So with this, I would stop, but would be happy to take any questions. I'd like to acknowledge our team at Vellore, with the help of whom we've done some of the work that I showed. Thank you very much.
Now we're going to have the second speaker, who is nobody but our Dr. Sanjay Kalra, who has been introduced, a well-known endocrinologist all over the world. So he's going to talk about the heart of transition, compassionate practices for gender-affirming care. So without much ado, ladies and gentlemen, please welcome Dr. Sanjay Kalra.
Thank you, Madam Chairperson and Chairperson, sir, for inviting me. And thank you, everyone, for once again making me part of your family. But thank you especially for giving me this topic. Let us read the topic carefully. The heart of transition. So this topic, it comes from the heart. For doctors, for transgender people, it is something that is very close to the heart. Compassionate practice. The word compassion, that is what Myanmar philosophy is. That is what Buddhist philosophy is. So that is also there in our topic. Compassionate practice is not just about preaching, is not just about theory. It is actually about practice in our OPD, in our clinic. So this topic touches our philosophy, it touches our practice, it touches our very being as human beings, as Myanmar nationals, as endocrinologists, as physicians. For gender affirming care. So we want to care for our patients, we want to care for our society, and we want to do it in an affirmative manner. Everything that you could think about is there in this topic. So thank you, Chairperson, sir, once again. Thank you, Madam, for giving us this topic, for giving us the chance to revise and to revisit what it means to be a doctor. We get inspiration from Lord Buddha. And it is said that there are two wings of a bird. When you want to fly, when you want to live your life, you need two wings. Each bird has two wings. One is karuna, that means compassion. Karuna is Sanskrit word. What is the word for karuna or compassion in Myanmar? Compassion. You'll give mic to ma'am.
Gyuna. Gyuna there, sana there.
Right.
And in other words, it's a considerate. In Myanmar, it is gyuna.
And the Sanskrit word for wisdom, insight, that is pragya. Pragya. So what is the Myanmar word for wisdom, insight?
Pranya means the pinya, insight, your wisdom, in other words.
So similar words, and if you have these two wings, wisdom and compassion, then you can soar high, you can touch the skies as a human being, as a doctor. And this is all that we want. Only two things from Buddhism, that if we can learn the teaching of the Lord, that is, you need compassion and you need wisdom. So let us take this to transgender health. When we use the word gender, it has many meanings. When we use the word transgender, it has even more meanings. So let us look at some terms. Gender identity is how I identify myself as a man, as a woman, maybe as something else. That is my identity. Gender expression is how I express myself. Maybe I identify myself as a man, but I am wearing a lady's clothes, a woman's clothes. My gender expression is feminine. Gender identity and gender expression can be concordant. In the vast majority of us, it is concordant. So I will identify as a man, I will wear a man's clothes. I will cut my hair like a man. This is concordance. But sometimes there can be discordance. I am born a man, I live like a man, but I like wearing ladies' clothes. Apart from that, what is the sex assigned at birth? So at birth, every child is assigned to be a boy or a girl. That is a separate part of gender. This is how you identify. Sexual liking, disliking is something different. That is that you may be attracted to a man or a woman. You may be attracted to both. You may be attracted to none of them. There is one word, sapiosexual, S-A-P-I-O, like Homo sapiens. Sapiosexual means you are attracted to someone who is very intelligent. So different types of there. It is a very wide umbrella, and this is known as the rainbow umbrella. In general, the sex that is assigned at birth is based on the chromosome or based on the phenotype. So the midwife or the obstetrician, she will look at the baby. She is not going to get the karyotype done. She will look at the baby and she will say, yes, this is a boy or this is a girl. But sometimes there are disorders of sexual development, or there are differences. So sometimes, maybe 1 in 1,000 births, the midwife will say, I do not know whether this is a boy or a girl. There is 𝗙𝗿𝗃𝗃𝗃, but I am not sure whether this is a clitoris or not. The phallus is very small. I am not even sure whether it is a phallus or not. That is intersex. That is different. Once the child grows, then the child experiences that I am a boy or a girl. That is the gender identity. And the gender expression is how the boy or the girl begins to behave, what kind of games, what kind of clothes the boy is choosing. Usually, like we said, this is concordant. And so, in a binary world, you will have men or you will have women, and there will be no problem. But now let us look at taxonomy. When you classify things, taxonomy means the science of classification. When you classify living beings, for example, as being plants or animals, 99% you can classify properly, but there are some organisms which have some characteristics of plants, others of animals. You classify animals as vertebrates, invertebrates, 99% classification will be okay. 1% there will be some kind of animals that will be hemichordate. So you don't know whether they are invertebrate or vertebrate. In vertebrate you have mammals. So you say all mammals live on earth, but then there are some mammals that live in the ocean. So see, so many things, classification is there to help us, but classification is not black and white. The more we learn, even for living versus non-living organisms, earlier the classification was easy, but then we discovered prions. So now we don't know whether a prion is living or non-living. The point we want to make is that the classification of men and women is not absolute. You can have something in between. And that is what we will talk about. There are people who are born men, but they feel that they are women. There are people who are born as women or girls, they feel that they are men. These are transgender people. Do remember that transgender is not a noun. A transgender person, transgender is adjective. A transgender person will feel offended if you call him or her, if you call them as transgender. It is an adjective, so you can say this is a transgender individual. That is a transgender spirit. That is a transgender beautician. So it is used as an adjective. Let us understand various terms before we go forward. We have already talked about gender identity, how I view myself. Gender identity disorder is an old term. Now we use gender incongruence. Gender identity disorder or incongruence means that I am born with one gender, but I view myself or I identify myself as a different gender. So this is not a disease. It is a physiological state. And to correct this physiological state, we need gender reassignment. So the child, the adolescent or the adult may come to you and say, I want to become a man because inside I feel that I'm a man. I want to become a lady because inside I feel that I'm a woman. The treatment that we will offer to them is gender affirming care. We want to affirm their gender. The gender affirming care that we offer is offered by multiple specialties, but the leader is the endocrinologist. And gender affirming care is of different types. The endocrinologist will lead, other people will support. And the care that you can offer to a person who is coming to you with gender incongruence is, first of all, lifestyle modification. Lifestyle modification will include multiple things. We then talk about psychological first aid, psychological support. We then move on to endocrine and metabolic care. And at the top of the pyramid is surgical support. Throughout transgender therapeutics, you will need social, legal, and supportive help. One should be aware of the laws in our country. So whatever the laws are, we should respect. But at the same time, if someone comes in the clinic, just remember the two principles of Buddhism, Karuna and Pragya. That is compassion and wisdom, or compassion and insight. So we should be able to offer compassionate care from the heart, whatever we are able to do. At the bottom of the pyramid is lifestyle modification. So all this we should be able to offer to everyone who comes. The least that that person expects from us is that we should listen to the patient. Do not be judgmental. Do not be sarcastic. That person is also a human being. That person is also created by God. Do not look down upon the patient. Do not look rudely at the patient. Look at the patient as a human being. And you will offer the following S's. S for sensible sustenance or dietary therapy. S for structured physical activity, sports. S for stress management, sleep hygiene. And in the transgender community, we have to be very careful about substance abuse management and also safe sex practices. So this is also part of our counseling. And social support, either we offer ourselves or we refer to the right person, maybe to religious body or NGO to offer social support. One S is stress management. And here I would like to talk about psychological first aid. This is something that we should give to every patient with chronic disease, anyone who is coming to our OPD. You are giving metabolic first aid, correcting, let us say, the sodium or potassium. We are giving glycemic first aid, correcting the glucose. Vascular first aid, correcting the blood pressure immediately. So I may say, right now, let me give you nitroglycerin drip, but I do not know why you have accelerated hypertension. Tomorrow I will refer you to Professor Ymint, and he will do the workup for secondary hypertension. Even if I cannot do a workup for secondary hypertension, at least first aid I can do. And I will refer my patient, that is the correct professor for hypertension care. Psychological first aid means the first and immediate psychological assistance that you will give to anybody. And the aim of psychological first aid is to preserve life. This is very important in transgender community. We will talk about that. It is also to prevent worsening of psychosocial health. Again, very important for transgender people. And it is also to promote recovery until the specialist can see. All this psychological first aid should be offered by the primary care physician and by the endocrinologist. It's not difficult, like I said. When anybody comes into your OPD, what do? I came to Myanmar, I was welcomed warmly by our chairpersons and by entire MSEM. I was asked, anything that you want, how can I help you? That is how we greet the patient. We welcome warmly and we say, how can we help you? Patient says, this is what I want. I have got a pain in my stomach. Then you acknowledge, yes, I understand that you have a pain in your stomach. For this, I want you to tell me whether you ate noodles in the morning or whether you ate street food last night. So you acknowledge, I have heard you, and then you ask the patient to tell the truth. Now, then patient says, I drank 12 pints of beer yesterday. Don't be judgmental. You know that the beer has caused the pain abdomen, but you say, yes, I understand. Next time you don't drink 12 pints, you share with a friend. So you have 11 friends, then you will get only 1 pint, you will not get pain abdomen. And your 11 friends will also be happy with you. So you explain with empathy, and then you reassure the patient, yes, I can fix you up. You do not need an ultrasound. Take this medicine, come back after 3 days. This is all that we do in the OPD, isn't it? But see, WATER, welcome, ask, tell the truth, explain with empathy, reassure in return. If you water the plant of conversation in the clinic grows, the plant grows. And from all our senior doctors, we understand that is the skill. So for the younger boys and girls, this is what you must learn when you are in medical college. You learn how to have a conversation with the patient and water the plant of compassion, water the plant of wisdom. Coming back to our topic, we talked about gender incongruence or gender dysphoria. How is this defined? This is when an adult comes and says, or an adolescent comes and says, that at least for the past 6 months, I feel that my assigned gender, society has made me man or woman, my assigned gender is different from what I am feeling inside. It is different from what I want to be. I want to be like the other gender. I want to get rid of my existing phenotype. If the patient says all this and that feeling has lasted for more than 6 months, then the patient has got gender dysphoria or gender incongruence. This is not considered a medical disease anymore, a psychological disease anymore. It is considered a sexual disease, and it is being destigmatized across the world. If the patient does not have, if the person does not have any other psychiatric comorbidity, the person understands the needs of therapy, then we can start treatment. If you remember the pyramid, first you will give general support, psychological support. You make sure there is no psychiatric disease. After that, then you give hormonal support. Only after that surgery will come. Hormonal support can be offered to any person who is above the age of 18. Again, be aware of the laws, be aware of the rules of our country and do not break the laws. But there will be red flags. So supposing patient comes and tell you, I want to self-harm. I have tried to commit suicide. I am thinking of ending my life. Then immediately the person needs psychiatric help, and also the person here will need hormonal therapy. And hormonal therapy aims to change the hormones. You want to reduce the male or female hormones which are offending, and you want to increase the female or male hormones which the patient wants. Each person will have a different requirement. Some people will say, I want to change my phenotype. Others will say, I want to preserve my fertility. Yet others will say, I don't want to preserve my fertility. Some people will say, I want surgery. Others will say, I do not want surgery. Our responsibility is to listen to the patient and try to meet their expectations as much as possible. Whatever decision we make, it should be informed. We should inform the patient. It should be share with the person and their family. And also it should be dynamic. We can always change. So you might tell the patient, yes, let us take hormonal therapy for 6 months. Let us see how you feel. After that, we will talk about surgery. Or patient may say, I went to Thailand and I got top surgery done, breast surgery done. So, okay, that's fine. You come back, wait for 1 year, then we will think about bottom surgery. So it is dynamic. One tool which helps me in diabetes, in obesity, and also in transgender health, this is the word black. So whenever I am talking to a patient about any investigation or about any therapy, let us say insulin, let us say estrogen, let us say testosterone, I remember that I have to complete the word black in my mind. I have to tell the benefits of the treatment, the limitations, the adverse effects, the cost, and the knowledge that is required. So based upon the person's needs, we will talk about the benefits of hormonal therapy, the limitations, what are the anticipated or expected adverse effects. Also, we have to talk about cost of hormonal therapy and monitoring, and the knowledge that is required. And for each type of patient, it will be different. In general, in transgender health, you will have two types. One is male to female. So these persons will be called trans women. A woman who is a woman from birth is a cis woman, CIS woman, or cis girl. A trans girl or a trans woman is someone who was born as a man, but now she is transitioning to womanhood. So this is male to female therapy that we give. Female to male is a trans male, trans man, that is a person who was born as a woman, but now wants to become male. So these are trans men. Trans men and trans women, basic testing should be done, all medical testing, and basic testing for, in general, pituitary, thyroid, adrenal, gonads. Just remember that you have to check for pituitary, thyroid, adrenal, and gonads. Because the phenotype is influenced by the adrenal and the gonads, and the adrenal and gonads are influenced by the pituitary. Apart from the hormonal testing, medical testing is also required. So hematocrit is required because when you give testosterone, hematocrit might increase. Liver function test is required because estradiol is not metabolized properly in patients with severe hepatic impairment. If you have severe hepatic impairment, it's a good idea to stop the hormones for some time. Lipid levels may change with hormonal replacement. Theoretically, estrogen can worsen insulin resistance, but not practically. Sometimes when you give hormone suppressants, osteoporosis can occur, so we should check for bone health. And also hyperkalemia is very rare with spironolactone, but still we should be aware and we should check for sodium potassium. And because this community is at higher risk of sexually transmitted disease, all the blood-borne diseases must be tested for. So this is basic testing that we do. How do we treat? If you have a trans man, somebody who wants to become a man, then we will give testosterone. We can give oral, injectable, or transdermal testosterone, whatever is available. In my OPD, in general, I start with oral because that is cheap and it is reversible. So we just start oral, maybe 1 capsule a day. For men, the dose is 3 to 4 capsules of 40 milligram. We give it for 10-15 days, see how the patient feels, and then comes back. If the patient can afford, I prefer transdermal because it gives a very smooth effect. If patient cannot afford, then we give injection. You can give aqueous or lipid-based, lipid-soluble injections. And depending upon the type of testosterone, it will last 2 weeks, 4 weeks, or even 6 months. So we start testosterone, but in my OPD, I usually start with oral or with transdermal, and then continue based on cost. You have to check the testosterone. Now, this is a woman whom you are giving testosterone. So what is the level that you want? You want testosterone to come in the lower level of male range. So look at the male range, that is our target. So in my lab, it is 250 to 850 nanogram per deciliter. So I will target 250 to 300 nanogram. And in the OPD, many times you don't have too much time to discuss. So you don't have to do everything on one day. You just tell them, I'm starting like this, and whatever you feel, come back after 1 week. Tuesday, my OPD is light, you come on Tuesday, and we will continue the discussion further. For women, for trans women, you need to give feminizing hormones. So here 2 types of treatments are done. First of all, we give estrogen. You can give oral or injectable. Usually most of us use oral estradiol. Transdermal is also available, but is very, very expensive in India. Apart from that, because you are converting the person from male to female, so you have to suppress the male hormones. For that, we give spironolactone. So you will give 2 types of treatments, spironolactone or cyproterone. My maximum experience is with spironolactone. And also we will give estrogen. My maximum experience is with oral estrogen. We have 2 milligram tablets in our country. Usually I start with half tablet at night and then go up to 1, and then we can increase 1, 2, 3 tablets of 2 milligram. Again, we titrate every 2 to 3 months, and our aim is to reach the lower part of the normal range for women in estrogen. So let us repeat again. For trans men, we will give testosterone. For trans women, we will give spironolactone plus estrogen. Axillary therapy will also be required, maybe laser, maybe a fluorescein local treatment. And you have to keep on monitoring. Trans men will usually want that there should be no menstruation. That is quite fairly easy to achieve. In patients where you are not able to achieve this, you can give GnRH receptor analogs like luprolide. The target therapy, like I said, lower half of the target range for estrogen and progesterone. Complete change in phenotype you will not get, but over 6 months to 12 months, you get fairly good change in phenotype. And if you can show the order that this is the way your phenotype is going to change over 1 to 2 years, patient feels satisfied. You have to be careful. You have to screen for thromboembolic disease in trans women and for erythrocytosis in trans men. Also for other diseases or conditions like high prolactin and like metabolic syndrome. Don't forget to screen for cancers as well. So if the patient has got, we call this organ inventory. You should know which organs your patient has. If your patient has got an intact uterus or intact cervix, you have to screen for that cancer. If patient has got intact prostate, you have to screen for prostate cancer, even if the patient is taking gender-affirming therapy. Sometimes the question will come, how long to treat? So in general, the answer is you treat until the expected age of menopause, until the expected age of andropause. But it is very rare that you will have a patient who continues with you for so long. So you treat each patient according to their need. Also, it is important to keep on monitoring the patient and to be in touch with medical personnel for medical management and in touch with the OB/GYN or reproductive medicine for fertility preservation. If patient wants to preserve fertility, they should keep their sperm or their eggs before you start gender-affirming therapy and certainly before you do the surgery. In that umbrella or that pyramid that we showed, first we had general help, 7S, then psychological first aid, then metabolic and endocrine care, which we can do. If you have given metabolic and endocrine care successfully for 12 months and patient says, yes, I still feel that I want to convert, I want to reassign, then we send for surgery, and you can have top surgery, bottom surgery, also dermatological procedures, plastic surgery procedures, and voice training. All these procedures will help in gender reassignment and gender affirmation. Let us once again, please join me in thanking our chairpersons and the MSEM team, the IDEC team, for having given us this topic. Treating transgender community, transgender people, reminds you to be humble. It reminds you to be human. But what do they want from us as a doctor? All they want is that we are confident in our work. We are competent. So we have come to IDEC to become more confident, to become more competent. At the same time, we should be authentic. So this is what I can do for you. This I cannot do. Let me refer you to Director General Madam. Reciprocal respect. If you respect them, you will get respect in return. That is the law of karma. Be empathetic with them. Do not look down upon. and just be simple human beings the way they are. And these two words again from Buddhism, compassion and wisdom. We pray to God that we get compassion and wisdom so that we are able to help our fellow human beings. Thank you.
Thank you, Professor Sanjay, for your excellent talk again on the transgender issue, which is now getting more commoner these days. All over the country, I think, and also in our country. Would you like to join us here on the stage? So, although two speakers have talked their topic respectively very comprehensively, there can be a room for discussion, any questions, any comments. First, Professor Nitin Kapoor has talked about new frontiers in obesity management, and second, Dr. Sanjay, Professor Sanjay Kalra has talked about the heart transition, compassionate practice for the transgender affirming care. So you can discuss. There are several areas, several issues you can clarify. We still have at least 5 minutes for discussion. Question and answer section. Start the ball rolling.
I'd like to thank Sanjay Kalra because this issue of the problem of the transgender gender affirming care in our country is still very rudimentary or not well developed yet. And also the people, the patient themselves, they are ashamed or they are reluctant to see the doctors. So they usually, they're taking these hormones by themselves or peer instructions. So they are like a hidden one. So I hope in future we can develop the transgender care properly in our country. For that, thank you. Any questions?
I'm pediatrician. Yeah. I have some cases of congenital adrenal hyperplasia. In our country, we do not have neonatal screenings and an awareness. So even the parents and even the doctors notice it is abnormal phenotype, but they thought it will be okay later. So we have some cases of congenital adrenal hyperplasia. So do you have any cases in your clinic, gender affirming and gender change, maybe in adult? Yeah, so please share your experience.
Thank you, ma'am. We have a wide spectrum of patients. There are some with congenital adrenal hyperplasia and others with anatomic problems that are discovered or identified during childhood. These percentage of patients are less in our OPD. Mostly we have adolescents and young adults coming to us. They come with the complaint of gender incongruence and they ask for reassignment. Like ma'am said, most of them are shy and they will go to their peers for treatment, for wrong treatment, but gradually they are coming up. So some things that we can do to bring these people into the open and to come to us, we can just begin telling our paramedical staff. That is the easiest way. So you go and tell your nurse that, or you tell your receptionist that we are going to begin working on transgender health. They will spread the message, people will come. But we should be aware of legal rules, first of all, in Myanmar. Do not break the law. Yes. Secondly, whatever you do, you take consent because it is a new field. Also, there is something called WPATH, that is World Professional Association for Transgender Health, and IPATH is Indian Professional Association. Then we have Endocrine Society of India. All will be very happy to work with MSEM to create a training module, and through this we can work. The CAH people will need different type of therapy. Adolescents will need different and adults will need different. Because it is a new field, it would be better that we first begin treating adults. That would be my humble suggestion as a senior colleague. Do not start treating transgender children below the age of 18. That would be humble, not even suggestion, it will be humble request. Please don't do. We can do after 2 or 4 or 5 years. After that we can do. So let us begin treating the adults. Also let us not work alone as doctors. Let us reach out to social organizations and also to religious organizations. Supposing the senior most monk says that yes, compassion and wisdom, this is what we want, then suddenly everybody will support you in the OPD. Supposing that monk does not support you, then it's a good idea to remain quiet for some time. Yes.
Yeah. Thank you,
Thank you,
both speakers, for very comprehensive talk.
Professor, moving on. Yeah.
Thank you. Question is for Dr. Nitin Kapoor. Actually, according to your lecture, anti-obesity medications, and these are very popular even in our country. So, but I think to get a sustainable improvement and management of obesity, because as far as I'm aware, for these drugs and the obesity medication, semaglutide, teriparatide, it should be used for the long run. And then if once we stop it, will there be a rebound effect? Or compare with the bariatric surgery, as you mentioned, like an intragastric balloon, what would be the best option for get a sustainable weight loss? I would like to get your suggestion and recommendation.
Thank you so much for that question. So you're very right that these medications will need to be given long-term. How I often in my clinical practice would tell my patients is like obesity is also to be managed like a chronic disease. Like for example, in diabetes, today I have a patient who's got an HbA1c of 10%. I start medications. In 3 months, the HbA1c is normal, but that doesn't mean I stop the medicine. I continue those medicines. If I stop, the HbA1c will spring back to 10 or even 11%. Similarly, obesity has to be managed like a chronic disease. The big concern of continuing these medicines long-term is the cost, but definitely semaglutide losing its patent in the next 3 to 6 months, maybe by February next year, I think the cost will come down. And the way we manage diabetes, we should be able to manage obesity. Yes, bariatric surgery is a very effective option, but again, for the right kind of patient, a patient who's able to do it and follow up after that regularly. It's not that bariatric surgery is free from weight regain. 10 years down the line, about 30 to 40% of weight comes back even for bariatric surgery. The last point regarding intragastric balloon, again, in my practice, the population that I use intragastric balloon maximally is people when they are referred to me for infertility, maybe in their late 30s. That's the time I cannot use these medicines because these medicines need to be stopped before pregnancy planning and then they will have weight regain. After bariatric surgery, I have to wait for a year and a half to plan pregnancy, and these are already elderly women. So their intragastric balloon is very effective. It costs about 15 kilograms of weight loss over a period of 6 months. So the infertility treatment improves. So that's one indication where I use it very often. Thank you.
Thank you. And you have mentioned a lot about normal weight obesity in the earlier part of the lectures. For the sake of the juniors, I want you to clarify. By using normal weight and obesity, it is sort of ironical. Two words are ironical. So could you, although you have talked about it, could you still explain to the audience what do you really mean by normal obesity, normal weight obesity, so that we can start the screening in they can be aware in their practice.
Thank you, sir. And yes, there is a paradox in the term because we are saying normal weight as well as we are bringing obesity. Obesity by definition is presence of excess of fat. So people who have a normal or a non-obese BMI, a normal BMI or a non-obese BMI for the Asian context is anything less than 25 kilograms per meter square. Anything more than 25 is obesity grade 1. For the Asian population. For the Western, it is 30. But less than 25 BMI in the presence of high body fat. Now, how body fat is assessed depends, could be less, done by high-end machines with DEXA, or it could be done by bioimpedance, or very simple methods as well. I showed you one simple formula to assess visceral adipose tissue. So presence of high fat, despite having a BMI of less than 25 kilogram per meter square, would define somebody to have normal weight obesity.
Right, thank you.
Okay. I'm
Yeah,
one of
there's
the
one person, yeah.
endocrinologists from Thailand. Regarding of the normal weight obesity, how can you treat them? And right now, are there any current medication or future medication for treating this group of patients?
Right, so that's an important point, and as I showed, lifestyle intervention follow-up of 10 years does very little to these people with normal weight obesity. At this point, no approved medication for normal weight obesity, but I know of ongoing studies both with semaglutide and tirzepatide, which is looking at treatment of this phenotype. So in future, we may definitely have indications based on fat despite normal BMI, but at this point, nothing is approved.
From Asian perspective, we can encourage our patients to increase their protein intake. So reduce carbohydrate, reduce salt, reduce rice, and increase protein intake. The weight will remain the same, but the body composition will become better.
And what about the fats? You talk about reduction of carbohydrate, increasing of the protein. What about the weight? Because there's one study globally showed that those countries with the increased carbohydrate intakes, they have the highest mortality of the cardiovascular diseases as compared to the high consumption of fats. Yes. So fat is not as bad as we thought previously. So what about the fats?
Carbohydrate is worse. If you look at the definition of diabetes, diabetes is a state of carbohydrate intolerance. It is not a state of fat intolerance. Second thing is that when you look at insulin release is stimulated more by carbohydrate, not by protein so much and not by fat. So if you take too much of carbohydrate, you will have more of hyperinsulinemia. In the Southeast Asian diet, fat is not a major issue. Palm oil, coconut oil are consumed, but the quantity is less. So you don't need to aggressively tell the community, provided they are taking traditional Southeast Asian diet and they are not eating burgers. But within fat also, we speak of macronutrition, that is fat, carbohydrate, protein. We speak of micronutrition like calcium, vitamin D. There is meso, M-E-S-O, middle nutrition. Mesonutrition means how much of saturated fatty acid, how much of unsaturated, monounsaturated and polyunsaturated. Are you getting enough essential fatty acids? So if you are getting enough MUFA-PUFA, let us say you take fish, then things are okay. But if it is too much of saturated fatty acid, like in the South Asian diet, in the Indian diet, we have a lot of ghee, clarified butter, that will be harmful. But the traditional Myanmar, Thai, Cambodian diet, that is very good from a fat and macro and meso perspective.
I'd like to ask...
Dr. Muyente, yeah, you will be the last. I'm afraid we are superseding the time allowed. Yes, please, Muyente.
I'd like to ask you to the professor.
Could you talk louder?
Regarding the side effect of the semaglutide, I have the one patient with the obesity. He also had the sleep apnea. So he already had the pre-existing proliferative retinopathy. So in that case, I'm very concerned about the side effect worsening of the retinopathy if he take the semaglutide. Do you have the experience for that?
Agreed. So that's an important side effect. Yes, the most common side effects, though, are GI related, but again, they can be mitigated if we start slow and gradually step up. The concern for retinopathy has been raised by certain clinical trials. We've even seen that in our Indian patients also. I would say that what is recommended as of today is to screen these patients regularly for retinopathy. If they have proliferative diabetic retinopathy to begin with, it is not an absolute contraindication. If you're going to be able to treat that adequately with laser and give the medicine but follow up, you can still possibly take the consent of the patient and treat. The main reason why these patients are developing the severe retinopathy, the main postulate is that with sudden reduction in glucose, very strict glycemic control, even if it was not by any of these drugs, but bariatric surgery or any other way, they could develop retinopathy. So I think good screening is what is recommended right now. And but if you take a consent and if you manage the proliferative retinopathy well with your laser therapy or anti-VEGF inhibitors, I think you can take a consent and still provide the benefit of the drug to the patient for the other comorbidities.
Yeah, regarding the anti-obesity drugs, now we have a lot added to the armamentarium of the medication, namely liraglutide, semaglutide, dulaglutide, and lastly, 𝗙𝗵𝗵𝗿𝗀𝗃𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍𝗍 semaglutide and 𝗙𝗵𝗿𝗫. 𝗙𝗵𝗿𝗫 is more effective in terms of weight reduction. If I remember correctly, after 2 years, 15.6% reduction of the initial body weight, whereas the semaglutide is only 9.6% efficacy. However, they are attended with sarcopenia. I have many patients, they have lost the weight, but also they have lost the muscle. So the weight training or strength training, don't forget to include when you use these medications. That is one point I want to highlight. Second point I want to highlight is that among the medication, liraglutide, semaglutide, dulaglutide, or the 𝗙𝗵𝗿𝗫, my experience, we need to also take into consideration of the quality of the life of the patient, which is measured by several dimensions. And one of the most important dimensions is the patient satisfaction after getting your treatment. My experience, as compared to semaglutide and 𝗙𝗵𝗿𝗫, most of the patients, they are satisfied with 𝗙𝗵𝗿𝗫. And less side effect and the more effective. This is just sharing my experience. So with that, I think, although we have many areas for discussion, may I request Prof. Sathyanarayana to wrap up and to conclude the session because we are overshooting the allotted time.
Now this is time for our conclusion. Winding up, the two speakers have clearly elaborated the new frontier on obesity management. Professor Nitin Kapoor has mentioned how to assess the obesity and why we need to treat and what to treat and where. So it's a very comprehensive aspect. And also, I'd like to thank Dr. Sanjay Kalra, who has showed how to deal with our patients, which is for the gender-affirming care practice in our country, because this is like a new perspective for our people, for our healthcare person. And we usually have some discrimination or stigma which has to be reduced by the time. So Dr. Sanjay Kalra has mentioned all how we show our the heart of transition, how we show the compassionate care for all these people. And also he mentioned how to assess these cases, how to manage, and how to assess the side effects and so on. So it was a very informative talk. So with that, I'd like to thank both the speakers for their very informative talk and with their visit to Myanmar as a speaker. I would like to welcome you. Hope we have more lecture from you in future.
With that, this session comes to conclusion. Thank you very much for your kind attention.
Thank you, our respected